Hello, my name is Sophie Sax. I'm a sophomore in the College of Arts and Sciences, and this summer I worked under the mentorship of Dr. Megan Lane Fall of the Department of Anesthesiology and Critical Care in the Perelman School of Medicine on the project called Handoffs and Transitions in Critical Care, Understanding Scalability, or HATRIC US. Going into detail on the HATRIC General study, this study came about when the literature showed that critical information is lost when patients are transferred from the operating room into the ICU. And clearly, this is a significant period of time where a lot of decisions can be made that impact patient outcomes. And previous Hattrick sub-studies researched the impact of a standardized handoff choreography on the thoroughness of communication between these teams of clinicians. And overall, the data showed that adherence to this protocol was correlated with a decrease in information emissions, which is what we were looking to do. However, some clinicians had mixed feelings about the idea of a standardized process and didn't want to go through the work of filling out more paperwork associated with a handoff or trying to remember something else. This is what brings us into the HATRIC US specific study. This is a mixed method study, meaning that we're collecting both qualitative and quantitative data to establish breadth and depth within our data. And this is a hybrid effectiveness implementation trial. We're measuring effectiveness in that we're measuring patient outcomes, but we're also measuring the success of implementation. So how well this new protocol is being adopted by clinicians. And the study seeks to work alongside perioperative clinicians to find a standardized protocol that works for them, not just an umbrella protocol that we're looking to implement within every ICU. This will ultimately close the gap between evidence and practice with evidence-based practice. There are 4 aims of this study, the first one being to ascertain the barriers and facilitators of protocol adoption and use within each ICU. Like I said earlier, we're using quantitative and qualitative data, the quantitative data being collected through surveys in which clinicians can express their opinions on a protocol in a uniform way, and also qualitative methods. So we'll be interviewing people from C-suite executives to nurse managers to clinicians, and we'll also be observing handoffs and recording strategic field notes on the ability of each clinician team in each ICU to communicate patient information. The second aim is to adapt a handoff protocol in each ICU. We'll be doing process map interviews with each clinician team, and the handoff team is made up of a surgical representative, an anesthetist, an ICU provider, and a primary ICU RN. And this team will work alongside the Hattrick research team to devise a version of the protocol that fits their specific goals, their specific culture, and their specific ideas of what makes up a successful handoff and a successful mode of communication. We'll also use data from AIM 1, but overall the core elements as listed in this graphic on the right will stay the same, but it's just the way in which they're carried out that can be adapted. The third aim is to test the effectiveness and implementation of these new protocols. They'll be implemented in each ICU with a stepped wedge approach, meaning that each ICU will have time pre-implementation and post-implementation, but the exact time of that switch from unstandardized to standardized will vary within each ICU. And effectiveness and implementation measures will begin to be put in place to determine the protocol's influence on the overall operation of this transition. So again, we're using quantitative and qualitative methods, the quantitative methods being mostly survey-based and the qualitative methods being interview-based and field note observation-based. The co-primary outcomes that we'll be measuring are fidelity, which is an implementation measure, and new onset organ failure in patients, which is our effectiveness measure. Fidelity will be measured in that we'll be collecting data on how many of the 10 steps were followed in each handoff. And new onset organ failure will be analyzed using a composite measure of AHRQ patient safety indicators reflecting organ failure. And our fourth and final objective is to create a tool that will allow for transferability of this method. We don't want this to only be possible within the 12 ICUs that we're working with, but we want to create a tool that would allow ICUs everywhere to work with their staff and collect data and ultimately come up with a process that will work best for patient outcomes, work best for clinician overall goals. I want to take this time to thank my PI and mentor, Dr. Megan Lane Fall, for encouraging me to ask questions and get involved and really grow a vested interest in this topic. Thank you for being dedicated to my learning. And thank you also to the PURM program for funding this opportunity. I really greatly enjoyed it. Thank you.